Um, so I met a few of you in the last session, but for people I haven't met yet, I'm Sarah O'Brien. I'm a pediatric hematologist, so I take care of primarily women who are in their teen years or in their 20s. And I'm also the hematologist for our pregnancy clinic at the Children's Hospital where I work. So I see a lot of pregnant patients as well. And this talk is geared towards younger patients, but these topics apply to women of all of throughout the reproductive years with bleeding disorders. So hopefully there's value in it for everybody. And please, you all took me up on this with the last talk. Please raise your hand if you have a question or comment during the talk. That makes it more interesting for everyone. And we had a lot of wonderful questions and discussion. Okay. So one of the things I want to talk about first is making sure that everybody's aware of the clues we use as physicians to know if somebody is having heavy menses. I think this is something that's still really under-recognized in the community. Right. We'll also talk about menstrual bleeding and iron deficiency and that association and how our like kind of the latest and greatest on how we're managing iron deficiency. And then the last part of the talk, we'll talk about some of the treatments that we use for heavy menstrual bleeding. And for that part, I'll be focusing a lot on the hormonal therapies that we use. So I love this quote from an article that's almost a decade old at this point, but it was an editorial in a journal called Thrombosis Research that was talking about, why are women and bleeding so understudied? And really that, half of the world is experiencing menstrual bleeding. So why don't we talk and learn about it more? And then I think, as we've already talked about at this meeting today, and as you're all well aware of, is that it's really been an under-recognized need in the community. Certainly, kind of the hemophilia treatment center world grew up taking care of primarily men and boys with severe hemophilia. And so we're still trying to like break that old mold, I think. And then I think the fact that people both healthcare providers and patients can be uncomfortable talking about menstruation, that it makes it harder to unearth what's going on and people don't know what's normal or abnormal. And then that ultimately leads to bleeding disorders continuing to be under-recognized in women. So if there's nothing else that I want you to learn in our time together, it's to know the 7-2-1 rule for heavy menstrual bleeding. Has anybody heard of the 7-2-1 rule before? Yes, so problem one. So this is something that we're really trying to use to educate people because it's easy to remember and sticks with three things. So, and we'll revisit it in a minute, but primarily it's a menses lasting longer than 7 days. It's having to change a product more than every 2 hours, and passing a blood clot more than 1 inch or the size of a grape. So those are the three simple warning signs. This is, I have the logo here for the Foundation for Women and Girls with Blood Disorders. This is another great resource for patients as well. And it is geared, the foundation is geared towards the education of healthcare providers, but many of the things are patient facing as well. And they have a 721 period podcast that talks a lot about a lot of issues relevant to you. So I encourage you to check that out. So I am someone who happens to have 4 children, and so when you have a child and you're about to go home from the hospital, they give you a diary, right, of diapers, and they tell you to write down how many wet diapers they have, how many poops they have, how many ounces they drink, or how long they breastfeed, and you're supposed to then take that back with you when you go to see the pediatrician. And so I think it's strikes me as ironic that 3 of my children are daughters, but when 12 years later, when your daughters are starting to have their periods, you don't get that diary or that education about what you're supposed to be looking for at home. Um, so for our patients with that we have met before they reach menarche with bleeding disorders, as we get closer to those adolescent years, we have a talk at their annual hematology visit about what to expect when they start having their period. And we talk about how we expect a menses to last 4 to 5 days, that the average cycle length for women is around 34 to 35 days, but that it can be normal for it to be between to have a period every 3 weeks, and it can be normal to have a period every 6 weeks, and kind of anything in between there. We talk about how the first cycle is usually the longest, so it's not uncommon for somebody to have their first period, and maybe they don't have another one for 3 to 4 months, and that can be totally normal. And we talk about how irregular cycles are really common. Um, so in my profession, I've collected a lot of worst period stories, worst first period stories over the years. So I'll say what's the number one so far, and if anybody has one they think that can beat it, you can share it with me afterwards. But so far, my worst one is in a rowboat on a trip with your grandfather at a cabin in the woods. So yes. He definitely did. She didn't know what to expect. He didn't know what to expect. Had to make a quick trip to, not a quick trip, but a trip to CVS. So here's the 721 rule again, and this is from a hematology consortium in Europe. So the one is a little bit different. But again, reminding you that a period should not last more than 7 days, that you shouldn't soak a product in 2 hours or less. And there they use a euro instead of an inch, the euro coin, as what your clots should not be larger than. These are some of the other clues that we use when we're trying to figure out if somebody is likely to have an underlying bleeding disorder. So we already talked about soaking through products quickly. Um, and I think this is, I've learned as a physician that I need to be really detailed about this because products have changed so much with time. When I first started, we just had regular tampons. Now there are super tampons, ultra tampons. So I need to ask my patients specifically what they're using. I think the other big difference is that adult diapers are much more readily available on the market. So I have patients that are needing to use those for their periods, and they may not bring that up unless I specifically ask them that question. We also have period underwear now, so and those can differ by brand. So it's important to know, like, you can look up what period underwear you're using and know like how many hours it should last, how much it is holding, and that can give you an idea of whether the blood loss is unusual. Um, we love menstrual cups, which are now on the market because those specifically tell patients how much they're bleeding. Certainly anyone who's using products but still soaking through clothes, soaking through bedding, having to get up at night to change your product is unusual. If somebody's been started on a typical standard birth control pill and their periods are still heavy, that's another clue for us. Um, Many patients, but not all patients with bleeding disorders, will have had heavy menses since they started having periods. When I see someone in the office who had normal periods for 4 or 5 years and now they're starting to have problems, that makes us think less of a bleeding disorder. We still want to rule that out, but it makes us be more suspicious of other maybe hormonal reasons for those changes. Because of we know that iron deficiency is a sign of heavy bleeding. If we have a patient who's anemic, that's a definite sign that they have heavy bleeding. And certainly if they have other bleeding symptoms or a family history of bleeding. So I know in some sense I'm preaching to the choir here, but I think it's also important because a lot of times we get questions about like, well, how do I know who else in the family should get tested, or what should I tell other people in my family what to look out for? One thing that really leads to a lot of delayed diagnosis in women with bleeding disorders is this concept of anovulatory bleeding. So I explain it to my patients as when we go through adolescence, the hormones in our brain need to learn how to talk to the hormones in our pelvis and vice versa. And it takes a few years for them to figure this out. So during that time when the hormones are learning to talk to each other, it's called immaturity of the hypothalamic, which is our brain, pituitary, brain, ovarian, and our belly axis. And what that leads to is irregular cycles during that first 1 to 2 years of having periods. And during that time, menses can not only be irregular, but they could be very light or very heavy or anywhere in between. So, what we don't like to see in clinic is someone who's been really struggling with periods for 2 years and they've been, told that they'll grow out of it. So, yes, the good news is that some aspects of periods can get better with time. But if somebody is having very heavy periods, they're developing anemia, they're not responding to therapy, or they have other bleeding symptoms or a family history of bleeding, they should absolutely be worked up for a bleeding disorder at that time, not waiting to see what will happen over the first 2 to 3 years. And then, so we always say they still require a laboratory evaluation up front. Now, what we'll talk about later today is then when we reach perimenopause, the hormones in our brain and belly like forget how to talk to each other. So then you go through a few years of that as well. And that can also be a particularly troublesome time for women with underlying bleeding disorders. Before I start talking about some of our management strategies, does anybody have questions or comments about what I've talked about so far? I'm curious if anybody's had an experience where they've been told that you'll grow out of the periods, let's wait and see what happens. Yes. Right. And I think that is, I mean, not only is a what to expect when you start your period, I think more needed, but then I think we forget to tell people what to expect then as you reach perimenopause. Because I think what happens a lot is women are busy. They're really good about seeing their hematologist during the teen years. They come back when they're pregnant. And then if everything's going well, they may like stop coming to see us. And so then when they start having struggles during that time, they kind of need to revisit, oh, wait, this could be due to my bleeding disorder. There are things that we could do for it. So I'm going to talk through the most common hormone strategies we use for heavy menses, and these apply throughout the reproductive life cycle. And whether or not women have a bleeding disorder, hormonal therapies are still the first line for managing menses. And that's because the tools we use from the hematology side are able to lessen bleeding, but hormone treatments have a lot more benefits to them. They can help control cramps, or dysmenorrhea is the medical term for that. They can help control the regularity of or like right before your period or during your period. So they offer all other benefits besides just heavy bleeding. So usually the ones that we will use first for patients are what we call a combined hormonal contraceptive. And most of the time these are used as pills, but there's also a contraception patch that people wear that they can put a new patch on once a week. And there's also a vaginal ring that patients can use that where they again replace that ring, kind of like inserting a tampon, but they replace that every week. But all three of those formulations have the same ingredients. They'll have some type of estrogen in them and some type of progestin in them. And there are, 85 of these on the market with different ingredients and different doses of the estrogen progestin. So sometimes when I'm seeing a patient, I need the first thing I need to do is Google the one they're on just so I know like what exactly they're getting. But So all of these work in similar way, which is they are thinning the lining of your endometrium, which is that lining that's inside of your uterus. And by thinning that endometrium, it's reducing the amount of blood that is produced during a menses. But the point I want to make here is that there are a lot of these on the market, but there are particular types that are best suited for women with underlying bleeding disorders. So often these will come in these packs that almost look like a calendar, and they'll usually give you a sticker to put with the days of the week over them. And these are the 4 weeks that you take your medication. Or sometimes they'll come in a circle, and you go around the circle during those 4 weeks. And typically, what happens in these medications is there's 3 weeks of an active medication, and then the last week is called the placebo week. And usually, those pills don't have anything in them, or for some formulations, they might have an iron supplement in them. And during that week, then is when the patient is expected to get their period. So you'll notice. So what's the difference between these two pictures? Right. So the pill on the top is what we call a monophasic birth control pill. So that means the woman is receiving the same thing for every day of those 3 weeks of active therapy. The pill on the bottom is called a triphasic pill. Just to give a brand name, like a common one is ortho-tricycline. So a lot of the times they'll have that tri in their name. Um, so what these pills are trying to do is mimic the normal menstrual cycle. So levels of hormones are going up and down. And there's nothing wrong with that. It's just that for a woman with heavy periods, they're more likely to have breakthrough bleeding when they are doing those hormone shifts. So it's better to have a monophasic pill. So for example, if I see someone who's on ortho-tricycline, I will often change them, and they're otherwise tolerating it well, I will change them to orthocycline. So same type of pill, hopefully same side effect profile, but like the dose of hormone is not changing throughout the month for them. So we want the other big common mistake I see is that, especially because I take care of young patients, is they are prescribed a hormone pill that is just too low dose. So most hormone pills will have an estrogen dose of between 30 to 35 micrograms of estrogen, but they have pills on the market that go all the way down to 10 micrograms. So those little pills are great for someone who doesn't have any problems with their period, wants a good contraceptive agent. Maybe they were nauseated with regular birth control pills and this one works better for them. But I find that when, especially a gynecologist who mainly sees adults, is seeing, a 12, 13, 14-year-old, they're apt to lean towards these really low dose pills. So many times we're then referred a patient who's failing hormone therapy, but they're actually not failing therapy. They're just on the wrong pill. And once we get them on a standard dose pill, they do a lot better. So what I want you to remember through all of that is standard dose, all the same color. So those are the types of hormone pills you should be using. Another treatment that we use a lot is an intrauterine device. And sometimes people will raise their eyebrows when they say that because they're like, well, you're a pediatrician. And I think that's because there's still a lot of misperceptions out there about the IUD. The reason why we love IUDs is because of all of the hormonal agents, they are the best one to really just suppress menstrual bleeding. Some patients do continue to have a monthly menses with an IUD in place, but for many patients, they may just have spotting or may not have a period at all. So they also work really well for patients that are struggling with menstrual cramps or mood changes during the menstrual cycle. It's, so a few misperceptions that I still hear in clinic are that IUDs can make you more at risk for sexually transmitted infections, and that's not true. Um, I also still hear that people think that IUDs are only for women who are done having children or for women who have started having children. So you have to have had a baby before getting an IUD. That's also not true. Sometimes people think that IUDs will negatively affect their fertility, and that's also not true. Once the IUD is removed, people are as fertile as they were before within a few weeks. Um, it's also thought that sometimes you have to be sexually active to have an IUD placed, or you will lose your virginity. I've had patients express that fear to me. And so we just talk more about like what virginity means versus having a medication in your uterus and how those are different things. Um, One thing in the pediatric world that has made IUDs much more accessible to our patients is that our pediatric gynecologists will do sedation, so for IUD placement. So that's really helpful for young patients who maybe haven't had a pelvic exam before, who are not sexually active, or even for our older patients who have developmental disabilities or some other reason why having a pelvic exam would be really traumatic for them. So light sedation with IUDs has really been a game changer for us. I think as a adolescent doctor, we also love IUDs because in terms of contraception, they are truly set it and forget it. So it's a fabulous form of contraception, more effective than pills or any other type. And while they can be in for 7 years, they don't have to be in that long. I had one, then I had it removed when I decided I wanted to have another baby, and then I had another one put back in afterwards. So they're really flexible. This picture is just to show you how small they are, and it's a like a rubbery material, so there's some give to it when you press down on that T. So those are the two that we use most often, but sometimes we have a patient who cannot use estrogen for some reason. So common reasons for not being able to use estrogen are if our patient has a history of blood clots or if there's a strong family history of blood clots. And we definitely have patients who have a family members with bleeding disorders, but also family members who have experienced a blood clot. We also sometimes have patients with bleeding disorders who experience blood clots. So these can go together. Probably the most common reason we see is our patients who have migraine with aura. So patients with migraine with aura, which means a migraine headache where you like see spots before that or floaters or get dizzy, um, they are not supposed to use estrogen containing medications due to the risk of stroke. I'm not sure what that. Oh, that's you. Okay, good. I thought it was me. So, just I'm not going to go through these in detail, but just so in the past, we were really limited on having progestin only options, and now we have a lot more options available to us. So we have different pills we can use, we have Depo-Provera injections that we can use, and then the IUD that I mentioned is also progestin only. Actually, though, that makes me one more point I want to make about the IUD. I wish they would be off the market, but there is still a copper IUD out there. And it's important to remember that that is not the one that you want to use. Copper IUDs provide contraception only and do not decrease heavy menses at all. Another thing that I want you to be aware of is the progestin only implantable, which the brand name is called Nexplanon. Is anybody here familiar with Nexplanon? Okay. Can I ask, did you have a good experience with Nexplanon? You did? Okay, that is great. You are in the minority. Uh, yes. That's great. So I do have some patients for whom Nexplanon has been a good choice. Like you mentioned, it lasts for 3 years, so it's another one of those set it and forget it options that can be great. We do find that for people who have heavy periods, sometimes the Nexplanon makes it worse. So I have definitely had patients that are coming to see me and they have a Nexplanon in, and we can't make any progress until we get that out. So it's not our first choice for people that know that they have an inherited bleeding disorder, but I do have some success stories with it as well. Any questions about that? Was a lot of information in 3 slides. Any hormone questions? Yes. I didn't, but I think that's because since I take care of younger patients, copper IUDs had kind of gone by we don't use them in that patient population, but some moms have shared horror stories with me. Yes. Yeah. I think it'll always stay on the market because there will be people that are really interested in not having a hormone for various reasons. But I also think there's still some OB-GYNs that don't know the differences as they should apply to women with bleeding disorders. I think I saw a hand over. Hmm. Yeah. Yeah. So there's a lot of good stuff packed into there. So one point I think is that I would say a main minority of women do experience some pain, discomfort after IUD placement and ask within a few months to have the IUD removed. Yeah. But and I've had one or two patients who had mood shift after it. I think that, as someone who can look back at the broader picture, those are rare. I think what happens is those are the people on social media, and those are the people, like a lot of my teenagers have, oh, well, somebody's IUD exploded out of their body. And like the bad stories are always the ones that people appropriately remember. But I wouldn't let a bad experience in one family member prohibit another family member from trying it, because I don't think it has anything to do with the underlying bleeding disorder. So I don't think they would be more at risk for having that issue. Um, we often do start with pills, especially in very young patients during the first 1 or 2 years of menses. And that's because of what I was talking about earlier, which, it is true that some of it could get better, like especially with your 11-year-old as her hormones mature. And so the pills are kind of nice because they're not, they're easier to tweak, or some, I've had a few patients that maybe these are patients with mild bleeding disorders. Maybe they needed hormonal contraception for the first few years, and then when they're a little older, they trial off of them. So it just gives us more flexibility. And then I forget what the last question was. Oh, thank you. Yes. So with the association between breast cancer and estrogen comes from the original generations of birth control pills. So the pills that we use now are called third and fourth generation pills. And just to give you a sense, if you remember, I said that a standard dose pill will have 30 micrograms of estrogen, an ultra low dose pill will have 10 micrograms, and a high dose pill will have 50 micrograms. The first generation of birth control pills that came out, they all had over 100 micrograms of estrogen. So they were much different than the pills that we use today. So we feel very comfortable saying that the birth control pills today do not increase the risk of breast cancer, and they actually decrease the risk of some of the other gynecologic cancers that women can experience. Yes. Mm-hmm. Mm-hmm. Yes. So I think this has also changed a lot in the last few years, whereas there were a lot of fears about hormone replacement therapy, and many women were encouraged not to use them. Um, I think, um, as my OB-GYN explained it to me at this point, it's really like I have a family history of breast cancer, but I'm still eligible to receive those medications. It's women who have a personal history of breast cancer who should not use them, and women who have a personal history of blood clots. I think for other women, it's your doctor will probably there's again, as I think people have seemingly in the general world, like finally recognized that menopause is a thing, like within the last 5 years, as some famous women finally went through it. But so I anticipate right now there are a few non-hormonal therapies on the market. I anticipate that market to explode over the next several years. So I hope that there will be more options. Um, but I think for right now, yes, it would be low dose or like focusing on other things for people who are at risk for thrombosis, but not completely contraindicated like it might have been a few years ago, if that makes sense. Yes. Say that last part again. Hmm. Yes, so that would have been around that time, and she may have been on the high dose one, or it may be that it's unrelated, that we know that breast cancer is so common, so it may just be true that she was taking hormonal contraception and that she developed breast cancer. But we know from being able to look at large population studies that when they control for other factors, that when similar women, ones who are on birth control pills are not more likely to get breast cancer down the road than ones who aren't. Other hormone questions? Yes. Mm-hmm. Mm-hmm. Yes, the Paragard is the copper one that the woman in the back was talking about. So that can definitely cause heavy bleeding. It's the mm-hmm. So the one that we use most often, the brand name of it is Mirena, and that is a progestin only IUD. Okay, I see. So that's why they chose the copper, but I would still anticipate that the copper IUD is making it worse. Yeah. There's also, speaking of teenagers there, and I'm blanking on the name of it. It starts with a K. I want to say Kyliva or something. There's an IUD that's marketed for teenagers that has a lower dose than the Mirena does. There's no real reason to use that. And again, for a teenager with a bleeding disorder, we want her to have the regular dose of medication. So we recommend that Mirena one for our patients, regardless of their age. The teen one is a little smaller, but I hope I reassured you with that picture that they're all small. I did want to mention norethindrone. I don't know if anybody's familiar with norethindrone, or the brand name is Agestin. It's one that we're using more and more. That is a progestin only option, and it's one that is really good for just stopping periods. So um, that is the idea, at least. So we are using it even for patients that aren't restricted to progestin only. And it can also be something that we use during a bridge. Like, for example, after somebody gets an IUD, you can have spotting for about 6 months after IUD placement. That can be particularly more bothersome for women with bleeding disorders. So sometimes we will use a double medication like IUD plus agestin for those first 6 months. Or if they were on a birth control pill and doing well and have decided they want to get an IUD for better control or better contraception, we will often recommend continuing their birth control pill for the first 6 months after the IUD placement to help get past that 6 month hurdle of the frequent breakthrough bleeding. There's not any harm in being on, there are no long-term side effects of it. Some of my patients, will ask, will this affect my fertility to be on these medications for long periods of time? And it won't. Once she chooses to stop it, she would be just as fertile as she was with before within a few weeks. So, right. It's also a nice option because it's progestin only, we worry about blood clot risk. And as we'll talk about later, sometimes we don't want women in their 40s to be on estrogen, for example, as their thrombosis risk goes up. So this is kind of a nice choice as well because there's not that estrogen piece to it. But no, the most common, some patients do great on agestin. The most common problems we see with agestin are weight gain and moodiness, and the moodiness can be very bad with the agestin. So I have definitely had patients who had to stop it, and we especially see those at higher doses. Yes. There's not really any, there's no need to have a period. It's not doing anything healthy for your body. But I think that is still a common misperception that, I think healthcare providers some still say that to patients. But so it's really about patient preference. I have some patients who prefer to have a period every month. So we pick medications that allow that to happen. I have some patients who prefer having a period once a quarter, and so we can play with the pills and patches to do that for them. And I have some patients who say, I never want to have a period. And all of those are fine. There isn't any risk to fertility or risk for cancers or such. There's really not, because the thing is, if you're on these hormonal medications, your uterus is not building that lining up. So it's not like some people will think like, well, I need to flush out my uterus every month. But the medications are stopping that lining from building up so that it doesn't need to be flushed out or cleansed, if that makes sense. Yeah. No, there really isn't. It's okay not to have one. I think one reason that some of the options that we use, like sometimes we'll use a birth control pill and we'll have the patient skip the placebo every month, um, which will often suppress menses, but then sometimes they'll have a random out of the blue period. So some patients don't like that, and they'd rather have a scheduled period every month or a scheduled period every 3 months. So it's really a lot about your preferences, and it differs from patient to patient. So your hand was up. But I think the concern is that patients with migraine with aura may be at increased risk of stroke. I would say that that's the data are not great there. And I think that there's also a need for studies. Like, again, we've talked about how estrogen doses have gone down a lot with time. So I think that needs to be revisited. It's really hard to do those types of studies, though, where your contraception is such a personal choice that it's really hard to do studies where you are randomizing patient. Like, people don't want to be randomized to one type of contraception versus another. You want to be in charge of that decision. So, and I think the other reason is that because we have other all these progestin only options, then that makes it easier for patients as well to not take estrogen if they don't want to. I will say, if I have a patient with migraine with aura who has been told that they shouldn't take estrogen, I make sure that there is a headache specialist involved, like is someone who's with expert in that really the one saying that. Any other hormone questions? You can certainly ask hormone questions later too, but okay. I want to mention antifibrinolytics, our friend tranexamic acid. This is a non-hormonal medication. We use this medication a lot. Many of you have probably had it before or after a surgical procedure. That's another common setting where we use these medications. But tranexamic acid is also specifically designed and marketed for heavy menstrual bleeding. It's best used for women who have irregular menses. So people who have really irregular menses, it doesn't seem to work as well. And it's also, you take it for the first 5 days of menses. So for my patients who are having, 9 to 10 day menses every month, this is not a great choice for them. I think the benefits of antifibrinolytics are that they're really well tolerated, very few side effects. Most patients have zero. The side effects we occasionally see are headache or abdominal pain that go away as soon as you don't take them anymore. I do think the 3 times a day dosing can be challenging, especially for teenagers. Studies have shown that it works almost as well if you use it twice a day. So that's what I often will have my like really busy teenagers or college students do, just so we make sure we're getting it in regularly. Um, and then this is also a great choice. Like sometimes patients don't want to be on hormones for a variety of reasons. Sometimes women have been on hormones, but now they want to try to get pregnant, so they need to come off the hormones. This is also a really popular choice for my patients who already know they have a bleeding disorder and are about to start their first period. So we'll go through all of the warning signs like I talked about at the beginning of the hour, and then I prescribe tranexamic acid for them to have at home. And then that way they know what warning signs to look for. They can call us to talk about any concerns that they're seeing with this first 1 or 2 periods. And then if we agree that it's heavy, they already have the medication at home to start, and we're not causing a delay. Or like if you're on Grand Pap on your rowboat, you know what you're supposed to do. So the other nice thing about these is we can we talked earlier about an 11-year-old who maybe has just started their period, and they may have one period and may not have another period for another 6 months. So the patient, the parent, and myself are all hesitant to start hormones right away, but we also don't want them to have a heavy period again. So this is a great choice as the periods are kind of settling in, because it's not influencing the menstrual cycle at all. We're just using it once menses come. So I definitely have patients that will use this for the first few months of menses, and then we revisit and they're like, it's not effective enough. I want to try one of the hormone options. Or maybe they're doing well on it and we just stick with this. Any questions about tranexamic acid? We also have a few patients where we will use a hormone plus tranexamic acid. Um, and if the hormone alone is not working well, it's important to make sure that those are patients with a healthy weight and no other conditions that would increase the risk of blood clots, but it is safe to use those two medications together. So I joke that heavy menses and iron deficiency go hand in hand. And so therefore, many women with bleeding disorders are at increased risk of iron deficiency. And I think we've made a lot of progress in this area over the last few years. What the threshold for treating iron deficiency should be, and also that iron deficiency without anemia is also a medical condition. So we'll talk about those things now. So I think everybody is kind of familiar with the fact that iron is involved with our blood. It helps us make red blood cells. We talk about it as a building block in the blood. But what's less well known, and even among physicians, is that iron plays these roles in all of these other areas as well. And so it affects many organs and tissues in our body. It affects how well our muscles are working when we're exercising. It's affecting how well our brain is working. So that is why iron deficiency with anemia is when the iron deficiency has gotten so bad that now the red blood cells are not being produced at the same rate. But iron deficiency before anemia can still cause all of these other problems with musculoskeletal function and brain function and energy. So these are not all, but these are some of the most common symptoms of iron deficiency. So fatigue is definitely the number one side effect of iron deficiency. Um, I think this can be really difficult to tease out. I said before that I take care of a lot of young patients who all teenagers are tired, right? They're on their phones all night. They're not sleeping the way they should be. Um, I also see a lot of pregnant patients. Everybody who's pregnant is tired, but that doesn't mean that we should ignore iron deficiency because it's just going to make the fatigue worse and it may be easier to manage. So we can do all of the other things to try to help with fatigue, but we can't forget about low iron. Other symptoms we see are shortness of breath. Again, my pregnant patients are told they're short of breath because they're pregnant. That could be true, but they could also not be as short of breath if we treated their iron deficiency. um, Muscle weakness, headaches, restless sleep, restless legs, that can be triggered by low iron, poor focus in school, having your heart feel like it's beating faster. Some patients will experience hair loss due to iron deficiency or thinning of the nails due to iron deficiency. Um, some patients tell me they know that they're iron deficient because they start to feel cold all the time. Like that's their sign that they recognize. So all sorts of things. And again, these symptoms will be worse if you are anemic, but they can also happen if you're not anemic. This was a study we did in our young women's hematology clinic a while ago, and we were just looking at patients that were presenting to our clinic with heavy menstrual bleeding. So some of these patients turned out to have a bleeding disorder, some turned out not to have a bleeding disorder. But and we looked at over 100 patients. So what is important from this study is that half of the patients that walked into our door were iron deficient. But and we knew that they were iron deficient because they had a low ferritin level. But many of them did not know that they were iron deficient before they came to us. Um, I don't know if any of you have ever been at the doctor and they do a point of care test to see what your hemoglobin level is. We also do a point of care test for hemoglobin, like when babies are 1 year old. That's another time you'll see it. Yes, exactly. Right. Right. But see, that's the misperception because they are not measuring your iron. They are measuring your hemoglobin. So you're right. So you're actually so you have iron deficiency with anemia. But all of the women with iron deficiency without anemia who are going to donate blood, nobody's checking if they're iron deficient. They're just checking if they're anemic. So but yes, that test is looking at your hemoglobin. Mm-hmm. 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 Yep. Mm-hmm. Sure. So let me piece that apart a little bit. So for the another test that we commonly do is called a CBC, right? The complete blood count. And so when we do a CBC, we're still not checking anybody's iron or ferritin level. We are just looking at different red cell parameters, and that's all of those letters, the MCV, the MCH, the RDW. And those can all give us clues to what type of anemia somebody might have. So microcytosis is when the red cells are small. And one of the common causes for red cells to be small is iron deficiency. But this study was also making the point that many of our patients with iron deficiency did not have small red cells. So again, just making the point that a blood count alone does not rule out iron deficiency either, because you could have a normal size red cell and still have iron deficiency. So you really need to check the ferritin level. And so the next question people ask is like, well, my doctor checked my iron level and they said that that was fine, and so I don't need to worry. So there's a big difference between the iron level and the ferritin level. An iron level is just like one point in time. What is your iron level right now? Maybe you had a steak last night, like maybe your iron level is really good right now. The ferritin level is what are your iron stores? Like what's your long-term iron situation? So that is the level we need to use. I don't know, does anybody have a family member with diabetes? So with diabetes, you check the glucose level, right? That's like their point in time. What is their sugar right now? But their doctors also check their hemoglobin A1C, which tells them how well has your diabetes been controlled since the last 6 months when I saw you. So iron and ferritin are the same thing. Iron just tells you what's happening right now. Ferritin tells you what's going on in the long run, which is what you want to know. Now, for somebody with who and I don't have all your labs obviously, but for somebody who we've fixed their iron, but their anemia is gone, but their red cells are still small, they might have there's something called thalassemia traits that also run in families that can cause small red blood cells. So that's one common reason that we see for that. Then I don't know why they're still small, but then but yes, I'm glad they ruled that out. But then if that's still happening, and I know for sure that the iron has been fixed, then I have some patients that run small and some patients that run big on red cells, and we don't have a good explanation for it. Yes, yes. I didn't plant you in the audience, but yes. Um, You're getting iron when you receive intravenous iron infusion, and that raises your ferritin level. So this has been a huge problem in the field because everybody has a different definition of iron deficiency. So this will be very helpful. This is coming out later this year. The American Society of Hematology put together an expert panel who did many things, but one of the things was to decide on what is the ferritin goal. And so I know we're up on time, so I'll try to be quick here. But the short story is the ferritin goal for menstruating and for the adults in general is 30, which is much higher than it has historically been. The World Health Organization used a cutoff of 15, and that's what we've been using for years. So this is very different. And the American Academy of Pediatrics is also going to be coming out with guidelines in the next year that mirror these. With for young children, it should be 20. For adolescents, it should be 30. I think the other keys that I want you to know about iron deficiency before I let you go is that we've also changed how we manage iron deficiency a lot. We've learned that with oral iron, less is more. Your body absorbs it better when you take it once a day or even every other day. Sometimes we still see patients being prescribed iron twice a day or 3 times a day to try to get it up quicker. Your body's going to not absorb it as well. And the other big difference is that we move faster to IV iron. A third of patients do not tolerate oral iron due to stomach upset and or constipation and or nausea. So we try it for a few weeks. If the levels are not coming up or the patient is not tolerating it, we're moving more and more quickly to IV iron. And the IV irons that we use today are much similar to birth control pills, are much safer than the IV iron from generations ago.